Good evening. My name is Alika Lafontaine. I'm an anesthesiologist practicing in northern Alberta. And since I started medical school 14 years ago, I've been fascinated by the role that cognitive bias has in health system design and clinical decision making. You may not realize it, but cognitive bias has a very strong influence on how you receive care. I'm going to ask you just to read through this paragraph quickly, counting the F's. So I'll give you 3 seconds. 1, 2, 3. And be honest with yourself. How many F's did you see? If you're like most people, you probably didn't see all 6. Now, there's 2 reasons why this happens. The first reason is that when we're taught to read auditorily. So when we think in our heads about this paragraph, the F's in scientific sound very different than the F's in of. The second is that when we're taught to read for content. So we tend to skip over small words, things like of, the, and. Now take a moment and read through these next 3 triangles, starting from left to right. 1, 2, 3. I expect you probably read Paris in the spring, once in a lifetime, and bird in the hand. But that's not what they said. It says Paris in the spring, bird in the other hand, and once in a lifetime. You see, even though I just told you that you have a cognitive bias, you still can't see. So let me ask you a question. Why are Indigenous patients so sick? Let's talk about what happens inside the healthcare system. When you come to me for treatment, you can present in 1 of 5 ways. You can be healthy with no medical disease. You could have a mild medical disease that you could ignore and probably not run into a lot of problems with. You could have moderate disease that you could ignore, but you probably shouldn't. You could have severe disease that you must address. Your body won't let you do otherwise. Or you could be in a medical crisis, where if you don't receive proper care within a short period of time, severe problems will occur. As a health professional, we provide one of 5 different services. We start with education. The hope is that when I sit down and talk to you about your medical disease, it will change the way that you act and behave, potentially avoiding you further problems down the road. We can observe more closely, looking from visit to visit or from moment to moment, whether or not things worsen. We may take those observations and record them in some sort of patient chart so we can reference them later or pass them along to someone else. If what you have is beyond my scope of care as an anesthesiologist, I refer you to someone who hopefully can help you until you get referred to someone who can provide what makes the difference in our healthcare system, which is intervention. Now, the definition of intervention is important to understand. If you see a health professional, it doesn't matter unless they make a difference in the problem that you have. Now, let's look at what literally happens when someone with diabetes comes to the mainstream healthcare system, the Medicare system that we're all very used to. If you're healthy, you tend to get some education. You know, there's school programs that talk about diabetes, healthy moving, talking about the disease, making sure that you avoid the things that could predispose you towards developing it. If you have mild disease, they may add an observation. And sometimes they may ask you to take a sugar diary, checking your sugars occasionally and looking on your calendar whether or not they get worse depending on what you do. If you have moderate disease, we add to that some sort of intervention, usually some sort of oral medication, something like metformin. As you get more severe, that oral medication shifts to insulin. If you don't receive, the high sugars can cause significant harm. Then if you present in a medical crisis, you know, in the case of diabetes, diabetic ketoacidosis, severely high sugars, or you have a stroke, or you have a heart attack. If you're at a clinic, you immediately get transferred to a high acuity center, where some specialist or emergency doctor provides effective intervention to ensure that you don't suffer more. Now, if you look at the Indigenous Healthcare system, things are very different. If you're healthy or have mild disease, the approach is very similar. But if you get moderate disease, intervention doesn't occur. This is a system design problem. Often the nurse who comes to visit you and record your sugars doesn't come frequently enough in order for you to see them, or they literally don't have the ability to start medication. Once you reach severe disease and you need insulin, the same problem occurs. So you get caught into this cycle where you're constantly referred from person to person, and no one on reserve may be able to help you. Interestingly, if you have a medical crisis on reserve, you need approval to be referred. We recently had a patient where they were skidooing up north. They ended up flipping, broke their leg, picked up their satellite phone, called STARS. A helicopter came, picked them up, and brought them to a tertiary center, as they should. The same patient in the same situation who lives on reserve would need to call their family. Their family would come out in their truck, they'd pull them out on their sled, they'd drive to the nursing station. The nursing station would then phone Health Canada and ask for approval to transport this patient to a tertiary care center. This process could take hours, and severe things often and do happen. When we look at the situation of Indigenous patients, there's cognitive bias that flows throughout the whole health system design and the way we make clinical decisions. Over the past week, we've heard about more Indigenous communities suffering through health crises. We've heard this in 2 different locations across Canada. What do we often hear inside the news? All of these things. In response to the health crisis that's happening in Saskatchewan, the news release that was received from the 2 levels of federal and provincial government literally said, we give these people a lot of money. We don't understand what the problem is. They live in a remote community. That's just how care is. But why does a patient living in Fort Vermilion, near the border of the Northwest Territories, receive a different level of care than the Indigenous community only 10 or 15 minutes away? So maybe the question we need to ask is not why are Indigenous patients so sick, but why are Canadians so healthy? There's many different reasons, but one of the specific ones is that there's a legislative framework in place. Your right to care is protected under provincial and federal legislation. There literally needs to be care. There literally needs to be quality assurance. There literally needs to be investigation. None of this legislation applies on reserve. For that reason, we started up the Indigenous Health Alliance immediately after the release of the Truth and Reconciliation Commission calls for action on health. We're breaking down the cognitive bias that leads to the way that we design this health system, the way that we decide to make these clinical decisions. We bring together the stakeholders who see things differently so we can understand what it is we don't see. We use process and tools to ensure that even though we can't see what we can't see, it's at least there. Cognitive bias remains a leading cause of death because we don't decide to change. Indigenous and Canadian disparities in health can be closed tomorrow if we choose. Thank you.